And of course, the treatment of small intestine bacterial overgrowth does not rely on breath testing for its diagnosis. You can diagnose that clinically, as I've reviewed already in this program. Again, I think this research was quite important. I actually think that if botanical medicines are therapeutically equivalent, then they are superior due to their lower cost and broader availability. As I'm sure most of you know who have experience in prescribing rifaximin, it is very expensive, commonly as much as $1,000, commonly as much as $2,000 for an extended treatment plan. Rifaximin is a very nice drug, but it is brutally expensive and certainly outside of the reach of many patients. So if we can treat those patients safely and effectively with an over-the-counter botanical preparation, then obviously that would be the treatment of choice. Again, I invite you to take a look at the article I published back in 2006, Nutritional and Botanical Treatments Against Silent Infections and Gastrointestinal Dysbiosis. You can find this on the internet for free. Now that we have reached, or we are reaching, the end of today's presentation, let's review again very quickly a few major concepts in evidence-based healthcare and evidence-based medicine, specifically as applicable to prescribing drugs for the treatment of infections versus the treatment of dysbiosis. So, for example, dysbiosis, of course, is a condition that involves microbes, but it's not really a true infection. But we can still look at the infection-based guidelines, protocols, textbook chapters, for example, to see what we might then glean from that information and apply it to dysbiosis-induced disease. So again, the major pillars of evidence-based medicine: patient's preference and autonomy, scientific research, clinicians' experience and expertise, and the social geographic conditions and circumstances in which we work. So let's talk about antimicrobial drugs specifically. Classically, at higher levels of what we might call clinical performance, antibiotic prescribing is based on practice guidelines, regional and hospital microbe profiles, perhaps available from your local hospital or local health department when you're treating true infections, that is. Culture and sensitivity results can certainly guide us clinically. Established long-term practice, again, such as the use of amoxicillin for acute otitis media. We can use published data and clinical trials and case reports, and we can use all of the above with consideration of patient tolerance and sensitivity. This presentation, of course, focuses on dysbiotic considerations, not necessarily infectious disease considerations per se. Again, more prescribing considerations here. We have to look at risk versus benefit, cost versus benefit. Pediatric dosing, of course, differs from adult dosing for a variety of reasons. Contraindications: some drugs are contraindicated in children, pregnancy, and with renal disease, or patients who are on anticoagulation or other pharmacotherapy. Maintaining or inducing antibiotic resistance through the overzealous use of prescription antibiotics, of course, is a topic that we all hear about. On the one hand, of course, it's very legitimate. On the other hand, modification of an individual patient's prescribing when 80% of antibiotics are used randomly in livestock, whether that's to prevent and treat infections or to give the animals obesity-inducing dysbiosis. And also, of course, the waterways are commonly contaminated with numerous drugs, including antibiotics. So I think that the overfocus on individual practitioner prescribing is the epitome of myopic micromanagement when it comes to antibiotic drug prescribing. Also, we note that so-called antibiotic-resistant genes have existed in microbes for thousands of years, and certainly before the advent of antibiotic drugs as we now know them. We might also note that the medical community as a whole has not voiced any resistance to the contamination of the American food supply and water supply with the antibiotic glyphosate, which Americans consume daily, and, as I've stated before, glyphosate is an antibiotic. So if we're really going to talk about the iatrogenic induction of antibiotic resistance through the therapeutic use of patient-specific antibiotics, I think we really need to look at that from a broader picture if we're going to have a legitimate conversation on that topic, especially when Americans are eating glyphosate every day, and glyphosate is certainly an antibiotic. And, you know, part of the issue with antibiotics generally is that the use of any antibiotic will select for non-specific antibiotic-resistant genes, and so a bacteria that's exposed to antibiotic A can then become resistant to antibiotic B. Well, if the entire food and water supply is being sprayed with glyphosate, which is an antibiotic, then we could be inducing antibiotic resistance in the microbial population of a given country, for example, simply by applying this pesticide, which also functions as an antibiotic, and thereby we are selecting for bacteria that have these antibiotic resistant genes simply through the overzealous use of this particular pesticide. So I think that deserves to be part of the conversation. Again, as I said before, when we're talking about antibiotic drug prescribing, we need to be able to differentiate between a true infection, which might have a certain level of clinical risk associated with it, for example, versus dysbiosis, which tends to induce and trigger long-term diseases. And so we're looking at a different risk-benefit profile, and therefore we are using different criteria to justify the use of antimicrobial agents in the treatment of dysbiosis-induced disease versus an acute infection. Also, as I said before, not all dysbiosis is directly contributory to a given patient's disease. So when we're working up our patients who have what we think is dysbiosis disease, when we get microbiologic data, we need to look at that data and evaluate to what real extent is this dysbiotic situation contributing to this patient's presenting complaint. So as I said before, just because a patient has a little bit of fatigue and dermatitis and they have a little bit of dysbiosis, it doesn't mean that we need to pull out the prescription pad, write them a drug antibiotic to address their very mild dysbiosis when the clinical situation really might not warrant that. And of course, anytime we prescribe any agent, we need to know how to use those drugs, the pharmacology, pharmacokinetics, pharmacodynamics, indication, microbial sensitivities, contraindications, drug interactions, and we will take a look at a few resources on the following page.